I'm Lynne Wilson-Orr. I'm one of the principals at Parkin Architects Limited. I am both a registered architect and an interior designer, and as such I am primarily a healthcare planner. I've been here for more years than I'd like to remember, 27 or 28 years at this point, and my primary function is planning clinical interiors, and I have a particular interest and expertise that I've developed over the years in women's and children's facilities. We had developed a very strong rapport, a very good working relationship, because one of the things that we really focus on is understanding what they do clinically. So we spend a lot of time with them to understand how they provide care and how different that is from perhaps the way care for babies is provided in other facilities. The fact that they're a tertiary care facility, there are residents, interns, fellows. What difference does that make? They have a very strong practice with nurse practitioners and clinical nurse specialists. That has a big impact on the program as well, and who gives care and how they give care. And this group of practitioners had a very different approach because they really looked at the parents as being equal members of the care team, and that was essential to them from the very beginning. So they felt that we got them. We understood who they were and what they wanted to do and how family-centered a program they are. It's almost 15 years ago that we first heard about the Gravens Conference down in Florida. And this group were the ones that said to us, are there any design conferences on NICU design? And this is when the group from Sunnybrook really came up with this idea of what's the best way to provide care? How do we really integrate families into this process? Science has developed to the point where they can maintain these babies at an earlier and earlier stage. And what has been wonderful to see has been the fact that as science has developed in terms of the medical care, it has leapt forward in terms of developmental care. And that was the thing that we really got from going to the Gravens Conference, was listening to people talking about how literally if you introduce sound and light at the wrong point in time in a preterm infant's development, you were rewiring their brains. And for me, that was one of those aha moments. We did some evidence-based design research. Elizabeth, plus the project coordinator from the maternal newborn side, and myself developed some questionnaires for staff to determine what staff felt were the most important design factors in the new unit. We had started to see that evidence-based design research was becoming more and more important in the design of healthcare. It couldn't be the architects and the designers' personal opinion about how things should be laid out, in the same way that it couldn't be a clinician's personal opinion. What there was evidence that was starting to say, if you put windows into staff lounges, for example, one study showed that there was a decrease in medication errors if the staff had a window as against having a staff lounge that was inboard and didn't have windows. So we looked at that, and what I've seen as a change in the last 10 or 15 years is the value of evidence-based design research and how important it can be in the design of a unit, because now we've got facts that we can base decisions upon. They're not personal opinion. They're not formed by cost issues necessarily. We can get information that allows us to say, if we do this, we can save you money operationally that will offset the capital cost. In Ontario, which is different from what it is perhaps in other jurisdictions, we are given a functional program that is developed by specialists who work with the hospital to review their operational programs, their staffing levels, and they develop a space list. And we're given that space list, but all it gives us is literally a list of rooms. So that what we do then is sit down with the user groups, and we have to go through a whole orientation process with them. Because for me, I know what a 10 by 20 room looks like. I know how big that is, but I can't expect that everybody else does that or understands that, because they don't do it every day. So our job was to take that space program and have it make sense to the users, so that they really understood that if their patient rooms were 160 square feet, what was 160 square feet? And how did they want these rooms to relate to one another? So we did a whole mapping exercise, and literally we took all the departments, every single room that there was. We're talking 120,000 square feet, so we're talking a lot of rooms, and we made squares and rectangles to scale of all the different rooms. We taped out on the floors how big 120 square feet was, how big 160 square feet was. And we took all these squares of paper and started saying, now what's your ideal relationship between these rooms? If you've got 48 babies, how do you want to provide care to them? Do you want to have 4 babies together? Do you want to have 6 babies together? How does your staffing work? How does your staffing work on breaks? At lunchtime, on weekends? What's the coverage for this? Is this 1-to-1 care, 1-to-2 care, 1-to-3 nursing ratios? And we worked with that to really get inside how they want to function. Because the biggest problem when you take a functional program or you start a project is that people think of what they have, they know they want it bigger, they know they want it better, but they often don't understand how they have adapted to the existing architecture that they have. And that if they didn't have walls, how would they do it? Well, if you say to somebody, if you didn't have walls, how would you practice? It's overwhelming for them. So we found ways to explain to them what that really meant. So that's why we went through all these different approaches of gaming, which is what the squares and the rectangles are. Then the mock-ups that we did. So we literally built full-scale mock-ups, first out of paper, and rolled isolettes and ventilators, kangaroo chairs, rolled them into these spaces that were literally just big pieces of paper on the floor, and said, okay, if you have a room like this, how are you going to function? How are you going to see into this room? Are the nurses going to be inside the room? Are they going to be outside the room? If they're outside the room, what can they see? What do they need to see? Where's the clean side of the room? Where's the dirty side of the room? So what we really do is work a lot with process. We are so process-based that what we do is meet with the users many times, because the first time you meet with someone, you're not going to get the full story. You can't. Nobody can think it through that completely. So what we did was a whole series of drawings at larger and larger scales showing what the spaces would look like. And we worked with all of the other users, not just the nurses and the doctors, but also the RTs, the pharmacists, the people from the lab, the people from supply and services. We brought them into the process as well and asked them, for example, diagnostic imaging. How are you going to bring your equipment into this department? Are you going to bring it into this department, or are you going to take the babies elsewhere? And because the hospital was moving sites, there were a lot of processes that really had to be developed. So the hospital had a parallel process while we were going through the design planning process of developing a lot of these protocols. So as those protocols were developing, we were building the drawings and continuing to ask the questions about how they were going to perform certain functions within the space. It was really working with all of the users at different levels and bringing different people in at different time, but maintaining consistency. And there were a couple of people from the hospital who were absolutely key to this. One of them was Elizabeth McMillan York, because she was there from the time we started the design drawings until the time they moved in, and she was responsible for making sure that all the questions that we asked were taken back to a larger group. The issues were discussed, debated, and then she came back to us with answers. So there was the consistency there, but there was also a critical mass of information that we were able to draw from. So it wasn't as though it was one person's opinion. We did the same thing in terms of the medical staff. Michael Dunn was at almost every meeting that we had. So were a couple of the other doctors, and that meant that we had input from the neonatologists, and not just the neonatologists that were working in the unit, but also the follow-up neonatologists as well, so that there was consistency and there was also continuity between what was happening in the unit and what was going to happen after the fact. So it was a very multi-layered process that we went through. But some of these babies are there for a long period of time, so we wanted to really look at the kind of environment that we were creating for them, and one that was supportive of parents, because when you have a baby in the NICU, it's very different. Most people, when they have a baby, expect that they're going to be able to go home with a baby, with their baby, and be a family within 2 or 3 days. But if you find yourself in the NICU with your family, your child, the rest of your family doesn't really know what to do, because it's like, well, are you really a family? Like, this isn't your nursery, but it's not an adult patient care area either. What is it? So we wanted to provide lots of opportunities for families to personalize the space, but to not try and substitute it for their home nursery, so that it would be a supportive, comfortable, welcoming space where they felt that they were there, and as I said before, they were an equal part of the care team, and that their baby was being well cared for. So that whole aspect of developmental care, we took from it being a medical process and tried to deal with that architecturally as well, because we felt that was really essential. Because of where this program came from and the restrictions on their old unit, they had to develop some very unique infection prevention and control practices to manage the situation that they were in terms of the large rooms. So we had an infection prevention and control coordinator who was part of every user group meeting, and she looked at the design, the layout. She was critical of every material that we used. We had to provide samples of every material that's used in the unit. We had to provide cleaning samples. We had to provide physical samples that they could then take away and use their cleaning materials and processes on them. We had to build mock-ups. So mock-ups not just of the rooms, but we had to have someone build a working mock-up of the sink to make sure that it was the right size, that you could get your elbows down into it, you could do a proper scrub, that the height of the faucet was correct. We went through every detail that that coordinator could think of to make sure that this was going to be a very safe nursery. And one of the things that they did that we haven't done anywhere else, but we have found that other hospitals have been starting to learn from them, is there is a clean side to the patient care room and there's a dirty side to the patient care room. So in the past, if they weighed diapers, they did it in one area. Now, they'd weigh diapers on a different side of the room from where they're preparing medications. And we've taken that to other clients and said, we think you should think about this, because look at their infection control stats and see the difference that it's made. There were three major challenges on this project for Sunnybrook. One was the fact that they wanted to have these separate parent corridors, and that had a very strong impact on the net to gross ratios because it essentially introduced 5 additional corridors within this space that had not been calculated in the space program that had been approved by the Ministry of Health for this project. So we had to find ways, because the users were absolutely adamant that they had to have those corridors. That was essential to their family centered care approach and this whole idea that parents are equal partners in the care of their child. So we had to find ways to really push the net to gross ratios everywhere else in the building. There are no excess corridors in this space. They all have a very specific purpose, and our space planning had to be really, really tight to make sure that we maximized use of the space that was available. The second challenge that we had was the fact that this NICU is built on top of an existing building. So it is an existing floor plate that was designed for operating rooms. It wasn't designed for NICU spaces. So one of the concerns that there was, and one of the biggest concerns that staff had, was natural light. And because the floor plates are so large, we had to work with them to understand where natural light was absolutely essential. And what we discovered using EDAC research, or evidence-based design research, and working with the users, was that it's the staff and the parents who need access to natural light. The babies really don't. For a lot of them, they're so preterm that they shouldn't have natural light. So we have to control the light that they're exposed to in a different way. So as a result of that, the floor plans got developed such that the natural light went into the staff work zones and the family zones. And we moved those to the perimeter of the building, and we moved the babies to the center of the building. And there were a lot of staff coming from the old facility that were used to having windows in the space and able to look out the windows from the baby care area and see what was happening outside. So for them, that was a very difficult transition to make. And we really had to work hard to help them understand who needed the light and what the light was for. And that's one of the reasons that all of the staff spaces, and not just the, shall we say, staff lounges and doctor's offices, but things like the isolate cleaning room, the nutritional formula and breast milk preparation rooms. They call it the Dairy Queen. It's a great space. There are women who work in there 8 to 10 hours a day. They don't get out. The nurses that are with the babies move around, go from one space to another space, leave the actual pod spaces to go and get supplies on occasion, so they get access to natural light. But the people who work within the pharmacy, the RTs, the Dairy Queens, they don't. So those are the rooms that move to the perimeter. Those are the rooms that got the windows. So it was difficult for some people to understand, but I think in the long run, we made some we made some very good decisions based on true staff and patient needs to decide where the windows were. The day that they moved in was an absolutely amazing day for everyone. The process of moving all the babies from the downtown hospital up here in ambulances, I spent the entire day with my fingers crossed that nothing went wrong and that when they moved there, everything worked. And I've been back to the unit a couple of times, and it's wonderful when I have talked to some of the families that have been there about the fact that they love the fact that they have their own door into the room. They have an address. They have a place that they can sleep. They're not asking permission to look after their babies. They have, the family washroom has a toddler-sized toilet in it, because that's one of the things that we were told by the families during the design process. And I'll hear stories about, well, so-and-so's, older sibling was toilet trained in the the washrooms in the family lounge. So it's been wonderful to meet those people and to hear that we made a difference in their lives by giving them a facility that has made them feel comfortable. I think you can tell that this is my passion. We actually just got an award last week for the new Women and Newborn hospital that will be built in Winnipeg through the International Academy for Design and Health. So we got a commendation for future healthcare design. And for me, creating a facility and working with the clinical staff to create something that will improve the experience that families have when they go through this is absolutely essential. I have not been through an NICU as a parent, but I've been through a lot of hospitalization with my own kids, and it makes a big difference if you're in a physical environment where you feel safe and you feel as though the staff are able to look after you and look after your child. That's very different than something where it looks like nobody cares. And with this nursery, with the whole Sunnybrook project, everybody who worked on that really cared about it. And I think it shows. You know, it started with them, as I say, drawing diagrams in the sand. And it's hard to imagine now, because it seems like, okay, it's open and it's working, but it was almost 20 years to get that far. And they went through horrendous experiences to get that far. I hope it was worth it. Hope it was worth the wait. Certainly, we learned a lot in the interim. It really became a passion for our design team. And I didn't do this by myself. I had a lot of help within this office, and we all took this on. All of the designers in the office had a photograph of a 2-pound baby that was on their desk to remind them that this is who our client was. We can't make a doctor a better doctor, and we can't make a nurse a better nurse, but with what we do, we can help them achieve their full potential. And that's really important to us.